Hello and welcome everyone to our presentation on ARDS, the subphenotypes. The Berlin definition, which was published in 2012, they define ARDS as an acute onset hypoxemia, that is with a PF ratio less than 300, with bilateral pulmonary opacities not fully explained by cardiac failure or volume overload. If we look more into the epidemiology and how it presents and the disease process, the study by Bellini et al., that is the lung safe trial, was published in 2016. It showed that there is an under recognition of ARDS, which may stem from the part that there is a considerable clinical heterogeneity. The syndrome may be triggered by various processes. Mainly, they are divided into pulmonary and extrapulmonary. The extrapulmonary are usually sepsis, aspiration, trauma, blood product transfusion, or pancreatitis. Pulmonary infiltrates can be focal or diffuse. Hypoxemia can range from mild to severe. The duration of respiratory failure can be brief or prolonged. And we have had very few positive trials in ARDS till now. Only PROSEVA and the ARMA trial have conclusively proven mortality benefits, and most of the other therapies have shown to have limited benefits or no benefit at all in patients of ARDS. This has been mainly attributed to the heterogeneity of the disease process and the fact that there is a lot of heterogeneity and there are a lot of methods by which a patient can develop ARDS, while our therapy may not be able to affect all these processes. Now, since this particular phenomenon of negative trials is seen in most of the specialities, FDA has come up with some guidelines to help the industry. These are called the enrichment strategies for clinical trials to support the determination of effectiveness of human drugs and biological products. Now, they have told methods by which we can enrich the trials, which means that we can enrich the population that we are taking so that we get more positive results and find better outputs in, especially in heterogeneous disease like ARDS, sepsis, oncology, like that. The first strategy is to decrease the variability in the study population. The second is to prognosticate enrichment, which means that we try to target those population who will find benefit. For example, if I do proning in mild ARDS, I may not find the benefit. Rather, I may find harm because of the procedure that I'm doing. So it is better if we can target our therapy to the population which will benefit. The third is the predictive enrichment, which means that if we have some markers by which we can know a particular therapy will benefit that particular patient. So let's see how we can enrich the ARDS trials by the subphenotypes. We will first look into the prognostic enrichment. So there are basically three criteria: the physiologic, the clinical, and the biological. So coming first to the physiological phenotyping of prognostic enrichment. The most common physiological phenotyping that is commonly used and the most frequently used one is the one in the definition, that is the PF ratio. We divide the disease process into mild, moderate, and severe based on the PF ratio, and it has been published and shown that it has a mortality difference. Now, the best part about this is that it can be easily measured, and we have already seen in trials like Acute, PROSEVA, and ROSE that if we look at the severe ARDS population, then the mortality range is almost like around 40%. So it is actually a good marker for prognostication. Now, apart from PF ratio, the other physiological markers which have been linked are the pulmonary dead space fraction, the ventilatory ratio, and the most recent one, that is the driving pressure. Now, the limitation with this is that these variables can change very, very quickly. They may change and become a severe ARDS can become a mild ARDS very, very rapidly. And the PF ratio, the area under the curve to predict severity and mortality, is 0.5. So it is not actually a very good predictor of mortality. Now, clinical phenotyping for prognostic enrichment. Here first we look at trauma-associated lung injury. It has been shown that patients with trauma-associated lung injury are less acutely and chronically ill than other forms of acute lung injury. And the better outcome in the trauma patients may be explained rather by the less severe lung epithelial and endothelial injury rather than the better physiological state when they are admitted to the ICU. The other thing that is looked at is the cause of ARDS, like the pulmonary and the extrapulmonary, the direct ARDS versus indirect ARDS. Here we can see, as far as the prognostic markers for mortality are concerned, for direct ARDS, you can see that age, lung injury score, number of organ failure, and diabetes mellitus. All these are a predictor of mortality. More so is the lung injury score. But if you look at the indirect ARDS, you can see that the only prognostic marker is the number of organ failure, which means that if there is an indirect cause of ARDS, mostly the lung injury is not really the most important thing that is determining the outcome. That is the disease process and the multi-organ failure which has caused the ARDS determines the outcome of the patient. So maybe these patients will not benefit from therapies that are specifically directed at lung recruitment or high PEEP or something like that. Now, here we look at the impact of acute lung injury. Here the patients were divided into three groups: no AKI, mild to moderate AKI, and severe AKI. Here we can see that the probability of discontinuation of invasive mechanical ventilation was lower with severe AKI and in mild to moderate AKI compared to no AKI. Similar findings were seen with mortality. Here we see the chance of mortality is more if you are having severe AKI with ARDS. Now, the other thing is the timing of the onset of acute respiratory distress. Sometimes the patient develop the ARDS late into the admission of the ICU. So it has been seen that patients who are admitted late, they tend to have higher mortality rate compared to patients who have an early development of ARDS. The other thing that we need to see is the rapid improvement of ARDS. That is, there is a certain group of patients who tend to have a very good response to treatment even though they are having ARDS. In this study, they classified the patient into two groups: the patient who had a rapid improvement to ARDS versus a patient who had ARDS beyond the day 1. Here you can see the patient who had a rapid improvement to ARDS, they had a better 60-day mortality, better ventilator-free days, ICU-free days, and non-pulmonary organ-free days. Now, if we look at the severity of the illness in these patients, we can see that nearly 63% of the patients who had a rapid response to ARDS would have been classified as moderate to severe ARDS on day 1, which means that we should wait at least 24 hours in any ARDS study to see how the patients are responding, because these patients may not be requiring more intensive therapy or any particular extra therapy for benefit. So if we include patients from day 0, that is without giving any treatment, we may include a lot of these patients, which may skew the results because they will not be requiring so much intervention for improvement, because they improve with the standard treatment within 24 hours. Now, the other method by which we can prognosticate is the CT scan. Here we divide the lungs into two parts, rather two groups. The one is a diffuse ARDS, the other is a focal ARDS. In the top picture, you can see that the lung has been diffusely affected, and the bottom you can see there is a focal lesion bilaterally. So both these things can have an impact on the therapy that we give and the prognostication. Apart from these, there are scores. This is the score which was given by Murray in 1988. In this, they looked into the chest X-ray, scoring, the hypoxemia scoring, PEEP scoring, and the compliance scoring. And this particular score has been used in the Caesar trial. So this is one thing which can be utilized in the trials. The other score that can be used is the Rails score. This was published in 2018. In this, they scored based only on the chest X-ray, the consolidation score, the density score, and the final Rails score was calculated by calculating the total from all the 4 quadrants. Now, there is a limitation with these clinical parameters. The most important is that there is always a misclassification because of the subjective assessment of most of these scoring and the assessment of clinical parameters. There is always a subjective effect into these scoring systems. So a lot of the times the patient tend to get misclassified. uh, I'll cite 2 examples. The first one is this particular study that is called the LIVE study. It was published in 2019. We'll go into the details of this particular study, but the thing that I want to focus on is the fact that nearly 20% of the patients had been misclassified. So as we can see here, nearly 20% of the patients were misclassified into the wrong groups. Now, the other problem that we see is this is a particular study looking into the alveolar recruitment based on pulmonary and extra. We keep on talking about direct and indirect, pulmonary, extrapulmonary. But if you look at the study results and how the studies are being done, here if you see the origin of ARDS in pulmonary was 41%, in extrapulmonary was 22%. But a major chunk, almost 37% of the patients who had an uncertain cause. So in this, almost in 40% of the patients, we don't know what was the classification. So these patients will be misclassified. Now coming to the next part, that is the biologic phenotyping, or use of biology or the biomarkers for phenotyping for prognostic enrichment. Now, we all know the disease process associated with ARDS is very complex. The first comes the exudative phase, the second is the proliferative phase, and last is the fibrotic phase. Now, there are various biomarkers which are being processed, and numerous genomic, transcriptomic, proteomic, metabolomic factors are being studied for this purpose. But majorly the biomarkers are being categorized under these 4 criteria. That is the biomarkers for systemic inflammation, epithelial injury, endothelial injury, and disordered coagulation. Now, how can we use these biomarkers to help in prognostic enrichment of our trials? Now, this is a subphenotypic study which was done of the one of the 2 famous trials, that is the uh, ARMA trial and the alveoli trial. In this, from this particular trials, they took almost 1,000 patients into their study cohort. 473 patients from the ARMA trial and 547 from the alveoli trial. In these patients, they looked into the biomarkers, that is the protein C, plasminogen activator inhibitors, and other various biomarkers. And they looked at how can they classify the patients into 2 groups so that we can prognosticate which patient is going to have a worse mortality or response to therapy. So based on this, they classified the patient into 2 groups, that is phenotype 1 and phenotype 2. And we can see here that the mortality seen with low PEEP versus high PEEP is much more in phenotype 1. If you are giving high PEEP, you are having a higher mortality rate, while in case of phenotype 2, you are finding a lower mortality rate. And this is statistically significant. And ventilator free days and organ failure free days are also lower in the high PEEP group in the phenotype 2, which means that higher PEEP is working more well in the phenotype 2, while it is not working so much in phenotype 1. So what are these phenotypes? So these are the two phenotypes, that is phenotype 1 and 2. In phenotype 1, you have a lower inflammation and better lung parameters. While in phenotype 2, you have a higher rate of inflammation and worse lung parameters, which means that phenotype 2 is a more severe disease process, which is called the hyperinflammatory ARDS, and the phenotype 1 is the hypoinflammatory ARDS. Now, this same group was again tested. This time they tested from day 0 to day 3. So the first trial that we saw was done at day 0. Now they wanted to see if this particular classification maintained till day 3, and they found that it maintained. Here we can see the changeover from class 1 to class 2 is very, very negligible and very, very few patients. So we can take it from these two trials that the phenotype that we see on day 0 continues at least till day 3. Now, this particular study, they included another group, that is they included the ARDS-net FACT trial, that is the study done on fluid and resuscitation on ARDS. So they included that particular patient group into this subphenotype. So in this particular study, they had three groups, that is three studies. That was, they included the ARMA, the alveoli, and the FACT trial. And in this again you can see that the 60-day mortality, 90-day mortality, and ventilator free days were worse in phenotype 2. So again they are confirming the fact that this subphenotype 2, that is the hyperinflammatory ARDS, is worse. Now let's see how the fluid resuscitation and the FACT fluid management worked. Here we can see that in the phenotype 1, the conservative fluid management strategy had a better outcome, that it had a lesser mortality in 60-day and 90-day, and better ventilator free days in phenotype 1. In the phenotype 2, we see that the conservative fluid management strategy fares worse. Here we see a higher mortality rate if we are giving conservative fluid management strategy in hyperinflammatory ARDS. Now, the identification and validation of distinct biological phenotypes in patients with ARDS. This was again a cluster analysis. In this, they found that patients with ARDS can be clustered into two biological phenotypes with different mortality rates. So the studies that we had seen prior to this were a retrospective analysis. This was a prospective study done in patients of ARDS, and they found 4 biomarkers which can be used to predict the phenotype with very high accuracy. Now let's see what are the genomics which have been done till now. Basically, there are just 2 trials. The first one looks into the interleukin 1 receptor antagonist and the lower risk of ARDS in patients who have an increased IL-1 receptor antagonist. The other is the microRNA markers which are associated with ARDS. So these are basically just 2 studies and they are still in the infancy. So right now genomic is not really coming into the clinical picture of clinical research. It is still in the benches. Now coming to the metabolomics, there is just a singular study. In this, the profiling of the ARDS pulmonary fluid in helps in identifying a metabolic distinct subset. Again, just a single study, and we can't yet convert it into clinical trials. So basically, based with all these knowledge, these particular authors, they tried to do a development of a algorithm which was cost effective and which would help us utilize these biomarkers in a bedside for further trials. In this, they found that they had 3 biomarkers. One first was the interleukin 8, the other was bicarbonate, the other was protein C. So if they included these 3 biomarkers, they found a very high predictivity, that is the area under the curve was 0.94. If you included the vasopressor use, then it was a 4 variable model. It increased the area under curve to 95, which is the predictor for mortality. So what we see here is use of these parameters helps in better predicting a phenotype, that is the phenotype 2, that is the hyperinflammatory ARDS, can be predicted by using these biomarkers. Now let's see how we can improve the predictive enrichment. So looking first into the physiological phenotyping. So a lower PF ratio not only identifies patients who are at a higher risk of death, but also reflects a greater lung weight, and these patients are more likely to benefit from recruitment maneuvers, higher PEEP and prone positioning. So it is always better to do these trials which are focusing mainly on the lungs on patients who have a worse disease, because patients with less severe disease may have harmful effects of these maneuvers. The next is use of clinical phenotypes. Again, the direct versus indirect. Direct lung injury in human is characterized by a molecular phenotype consistent with more severe lung epithelial injury and less severe endothelial injury. So as we can see, a direct lung injury affects the lung epithelium more and the endothelium less, while it is opposite in indirect ARDS. In indirect ARDS, the endothelial injury always is more compared to the epithelial injury. Now, we can utilize these parameters for our therapy. That is, a recruitment therapy may have more benefit in pulmonary ARDS, while a methylprednisolone may work to reduce inflammation in pulmonary rather than in an extrapulmonary case of ARDS. So we need to personalize the therapy based on what is the injury that we are seeing. So we come back to the trial, that is the live study, the personalized mechanical ventilation tailored to lung morphology versus low positive end expiratory pressure. Here the patients were divided into two groups, a control group which received standard treatment, then there was a personalized group. In this they tried to find whether the lung injury was focal or non-focal. If the patient had a focal lung injury, they gave the patient higher tidal volumes, a PEEP of 5 to 9. A recruitment was not mandatory, but prone positioning was mandatory. But in non-focal ARDS, they gave lesser tidal volume, a higher PEEP, and recruitment here was mandatory, but proning was only for rescue. So, as we have already seen in this trial, there was misclassification in almost 20% of the patients. So, based on that, we will see our results. On intent to treat analysis, that is including these patients who were misclassified, we do not find any difference in the survival. But if we look at the per protocol analysis, we exclude these patients who were misclassified, then we find a significantly improved mortality, significantly improved survival in patients who were given personalized therapy. So these results highlight both the promise and the perils of using the subphenotype. If properly classified, we will find benefit, but if misclassified, as much as nearly 20% of the patients will be not having any benefit, and we will not find any benefit in a large group of patients. As we have already seen, a higher PEEP has better outcome in hyperinflammatory ARDS compared to hypoinflammatory, and conservative fluid management therapy has a better outcome in hypoinflammatory ARDS compared to hyperinflammatory. Simvastatin and rosuvastatin have been used to decrease the inflammation, and mortality benefit with simvastatin has been seen in hyperinflammatory ARDS, while no benefit was seen with rosuvastatin. Now, beyond ARDS, subphenotypics have been used in other heterogeneous syndromes like oncology, sepsis, and post cardiac arrest. It is predominantly used in oncology, where specific markers are used to predict response to specific therapies. So this is something which should look forward in ARDS as well. So to conclude, therapy in ARDS are limited. The mortality still remains high. The negative results in various RCTs have frustrated many people and clinicians. But the identification of meaningful ARDS subphenotypes and the way in which the outcomes and the treatment responses differ promises prognostic and predictive enrichment in future trials. This may help fulfill the aspiration of precision critical care to be delivered to the patients of ARDS. Thank you. Thanks for your patience, and check our website for further details.